So anything that Dr. Kaufman and or I say should not be misconstrued as medical advice. Even if you are patients of ours, this is just purely for educational purposes and information dissemination. So this does not in any way constitute a patient-doctor relationship. This is just our joy of answering questions from the public, which is why we do the podcast to begin with. But so we just like to answer questions and know that we're at least giving information that at least some people are interested in learning about. So that's the whole purpose of our live events, which, like I said, usually has way more participants, but I'm not sure if the day, now that maybe now that the weather is changing, more people are outside. So we should consider that going forward now for the next
Yeah,
couple
but
of months.
all these people send questions in, so well,
Yeah.
whatever. Let's just go ahead.
Okay. All right. So for the people who are on and hopefully who will join, as they may know because they've been parts of the live in the past, you can either put a question in the chat, you can even raise your hand, use that hand waving option on Zoom, and then there were questions that were posted on both our Patreon page and our YouTube page. So we'll just we could just start with those kinds of questions. And so I have the YouTube page up in front of me. So one patient would like to know more about the management of hyperadrenergic POTS, especially after a while. Most of us are having trouble with orthostatic hypertension crossing dangerous numbers. So, what is hyperadrenergic POTS? I guess, first of all, so it's POTS with an elevated sympathetic tone, and the way that's usually definitively diagnosed with is with levels of norepinephrine. Oftentimes, it's very helpful to get those levels if you can in the clinic when you have a positive tilt table test that confirms the diagnosis of POTS. But many people will do the testing at home, or some doctors in their clinics don't have tilt tables, so they do orthostatics. And they too can actually test norepinephrine if the orthostatics are positive. But that is sort of the definition of hyperadrenergic POTS. And the management of it, there's a lot of overlap between hypovolemic POTS, which is another form of POTS, but there's a lot of overlap, but there are some specific hyperadrenergic ones. Which ones do you use, David?
Um, excuse me, beta blockers, guanfacine, sometimes clonidine.
Yep.
Excuse me. Um, I generally will try to start with beta blockers because they are a little bit less sedating, although they still can be.
Yeah.
Um, Plus, they address more than just hyperadrenergic. They usually have some other benefits, but often they don't work. Or they don't work well enough.
Right.
And then I go to guanfacine. I've moved over to guanfacine more because it's a little easier to taper off of if necessary, and it seems a little less sedating.
Yes, I agree with that. I like guanfacine over clonidine.
Yeah,
It's just tolerated a lot better for sure. And the key about hyperhidrotic POTS, of course, is that there is elevated blood pressure. So you don't want anything that could increase the blood pressure, which is why you avoid the ones that are more commonly used for hypovolemic, which is like fludrocortisone and midodrine.
right.
So yeah,
It gets a little tricky though because sometimes a patient will present with what appears to be hyperadrenergic POTS, but it's actually an appropriate compensatory response to a lack of volume, inadequate volume, and the body's trying to make up for that and raises, vasoconstriction raises the blood
right.
pressure. So it can be pretty nuanced at times. It's not
Yeah,
so, and
exactly.
there are a lot of POTS doctors, quotes, um, who think that that hyperadrenergic POTS or hyperadrenergic syndrome is part and parcel of POTS, that it's just built in. It's everybody's experiencing some of that sympathetic drive,
Yeah,
overdrive, I mean.
I agree. I mean, for a lot of my POTS patients, I actually have them sort of on a weekly basis, just give me a report of how their blood pressure and heart rate has been doing. And it does seem to go up and down. I mean, very often what I thought was a hyperadrenergic POTS patient, their documents will show low blood pressure. So, or not as high as you would expect. It's not necessarily hypotensive, but more on the lower end of the normal
Right,
range.
right,
So I agree with what you said. There's a lot of nuance to it, and sometimes it's a response to the management of what I thought to be hyperadrenergic.
right.
There's this level of now hypotension. So it's really important, I think, for all POTS patients that their doctors sort of, check in with them on a fairly regular basis, just to sort of make sure that they're managing the blood pressure and the heart rate appropriately, because they can these meds can get you into trouble if you're not
Yeah.
watching closely enough. So
And they require titration and adjustment. I mean, my patients, everybody's heard on on the Unraveled heard me rant and rave about the lean test, NASA lean test. I think it's a crucial,
Mhm.
if not one of our most important tools, because you can do it at home and you can do it every day or every week. And yes, it's very unpleasant for most of the patients, but it gives such enormously valuable information. One of the things I've noticed that's apropos to this conversation about hyperadrenergic is sometimes I'll have patients do it for 10 minutes, which is the usual, and you can see the elevated blood pressure. And then around minute 8, suddenly that blood pressure starts to plummet. And
Mhm.
now they become hypotensive. And it's as if that brings me back to that notion that there's sympathetic overdrive trying to make up for the fact that everything's messed up and raising the blood pressure, but it can't sustain it, which I think might be volume related.
Yeah, I mean, the autonomic nervous system, as I often say, is very complex. It can eat, with I think with POTS patients, it's very dysregulated, so meaning that it's very sensitive. So, a medication, even at appropriate dosing, or a movement or other stress, an illness, infection, exposure, physical or emotional stress even can trigger an autonomic dysregulated response. And so that's why I like to just check in with patients with a diagnosis of POTS, especially hyperadrenergic, because that means that they're always in sort of this sympathetic state. So, right, so always like fight or flight kind of thing. And so that a little thing can just sort of tip them over. And so I always like to check in with them to make sure that I don't need to tweak their medication regimen at all. So, okay, so then the next question to go to, um, it's funny because all these questions start with like thanking us for our podcasts and our live events. So, um, so I'm trying to find after thank you. Uh, it's too early for the time. Oh, so there's a time zone issue for this patient, but um, okay, I can't get to her question. Question. I'm very interested in heart rate variability as a tool for pacing and for assessing improvement or decline over time. Posted this question last time, but we didn't get to it. Uh, there's an app that she uses for assessing her heart rate variability. She's got ME, and she uses it as a tool for pacing. Any thoughts on the app, which is called Visible, or the larger subject of heart rate variability? I don't know that app. Do you?
Yeah, I actually have a lot of patients that use that app, and they
Oh,
find it very helpful. Um, it the only negative thing I'd say is it sort of spits out a lot of data, and it can be a little overwhelming. But patients say that they find it helpful in terms of monitoring heart rate and learning how to key their changes in heart rate to how they feel and also when it may be kicking off post-exertional malaise. So it can be a very useful tool.
okay. Yeah, I don't regularly monitor heart rate variability, but I do believe that it is a useful tool because on the autonomic nervous system testing that we do with the equipment in clinic, you get a reading of the heart rate variability. So that's the only time that I really look at it. And as long as it coincides with the rest of the results of the autonomic testing, then I don't use it all that regularly as I do with like heart rate and blood pressure from the patients. I ask them, like as I said earlier, I ask them to document it. But I do know that there are these apps. There's actually a couple of other devices that can be done for heart rate variability. So I don't use it nearly as often as I probably should, to be honest. It's just another marker to monitor
Right.
and treatment.
Yep.
Can you discuss each line item of the large list of comprehensive lab tests you order at the onset of seeing a new patient?
Are you
Also,
serious?
what inflammatory factors do you test for and what do they tell you? Um, well, I don't know specifically which line, all the line items of what you do versus what I do. I do know we both talk about how many labs we get with new patients.
Right.
And I think that just comes from years of practice of working with chronically ill patients, is that I just don't want to waste time anymore. I used to, when I started, just do a, set of labs, and then I would add to another set of labs, and then I would continue to do that. But I was just sending the patient back to the labs all the
Hmm.
time. Then I just felt like I'm just going to get them all. And so that's how my practice in terms of lab orders has changed certainly over the years. I think when we all start, we all have this idea like of how we're indoctrinated to think like only order, a finite set of labs. But I've quickly learned that with complex illness, that regular screening set of labs that we're all trained to do initially really doesn't tell you anything. So it's sort of, I just always felt like I was wasting time in trying to get to understand the patient better so that I can come up with, high utility recommendations for treatment and management options. So I don't, again, I can't go through every line item because there are quite a few. And this patient didn't specify which ones, but do you have something to say about your work?
Yeah, I mean, first of all, I agree. We've had this conversation, I think, a little in some other live streams. You and I, doctors are trained to order workups and testing sequentially, starting with the least complicated and easiest and escalate. And it has to do with the way we're taught to think, and also a lot of it's based on economics and not overspending.
Right.
Um, but I long ago in this with this population of patients decided, wait a minute, most of them have been sick for 10 to 20 years. They've been going from doctor to doctor to doctor. Every doctor says, well, you look fine and your labs are fine, so there's nothing wrong, or go exercise, or lots of other horrible things. Um, and so I really decided on day one of initial visit, new patient visit, I'm going to order a lot of work. And as my patients painfully know, it's usually 30 plus tubes of blood. And I can categorize it, and maybe that will help instead of doing it line by line. So first is the basics, a CBC, which is your red and white and platelet counts. Um, uh, Complete metabolic panel, which is liver enzymes, kidney function, and some electrolytes and things like that. So that's the basics. That's what most
And,
doctors would
right.
order and
Say,
say, "Oh, your labs are normal."
right.
Okay.
And
So,
those particular labs have
and
to
they're
be
always
like
normal. Those
multiple
labs are
times.
almost always
Yeah.
normal in our patients. Okay. And then I order a panel of viral antibodies and PCR DNA testing. We all have antibodies to EBV and CMV and HHV6 and HSV1. So that's not what I'm looking for. I'm looking to see if the numbers, the level of those antibodies are inappropriately high, or in the case of Epstein-Barr, that an early antigen antibody is positive, which shouldn't be positive unless there's activity. And they look for the PCR to get a gold standard test for reactivation. And then I'll do another set of those labs address immunologic function. So it's lymphocyte subsets, which are the T and B cells, which are often abnormal in our patients, and nobody tests them. That is not a routine test. I've never had a patient come to me who only saw basic primary care that had that test done. They come with it if they've seen other doctors who are learning what we do. So lymphocyte subsets, uh, immunoglobulin subclasses, not just the total IgG, which most people don't do, but the subclasses. I mean, most people don't do the subclasses. IgA, IgE, IgM, again, a broad assessment, sometimes mannose
Finding.
binding lectin. Thank you. Um, and then I do some antibodies for bacterial infections, partly because uh, they can be a cause of PANS or pandas-like illness, autoimmune encephalopathy, and also because they can cause autoimmune disease. So that's strep antibodies, ASO and DNase, chlamydia antibodies, chlamydia respiratory antibodies, not STD, and mycoplasma, pneumonia. Um, and then I will order in many patients, not always on first visit, a panel of vitamin levels because they're often abnormal because of um, limited diets, because of SIBO or because of mast cells. So, these diet limitations create deficiencies, so they can be counterproductive, obviously. um, I cover, inflammatory markers, CRP, C-reactive protein. Increasingly, I include lipid panels because I've come to think they're a reflection also of inflammation, and also they just should be addressed. Did I leave anything out?
Did you say the mast cell panel?
Oh yeah, thank you. Mast cell panel. Right. Histamine, chromogranin A, and tryptase, um, and prostaglandin D2. I actually often don't even bother with tryptase. It's just always normal and a kind of a waste of money. Um, but I definitely do the histamine, chromogranin A, and PG2. I'm sure I'm missing a few. So, but the point for the person asking the question and for other people watching or listening, it it's it's grouped in panels that relate to pathologies that might be driving illness. And I don't actually think I've ever had a patient who came to me as a new patient who said, I go to all these doctors and nothing's ever wrong. I've never had a patient come back with normal labs when I run all these labs. There's always things I find. Not because I'm smart, it's just because I ordered the labs, and that becomes potential targets that we can pursue both for diagnostic purposes and therapeutic, treatment purposes.
Yeah, I mean, I completely agree. I would, and I do just everything that you had just said. I don't do the vitamins nearly as often as you do. I add sort of metabolic labs as well, which is sort of a marker of mitochondrial function and sometimes oxidative stress. And then
Like one, like which one, Silent?
like uric acid and ammonia, lactate pyruvate, the acetylcarnitine
Oh,
profile, amino acids, organic acids, and things of that nature. Um, so I add that, and then I also will add like other organ function in terms of like even insulin or insulin antibodies and creatine kinase along with the aldolase, and I also add sometimes some clot labs as well just because now we know about endothelial dysfunction. And so it's nice to sort of know the risk of patients and their clots. And then I've got some other mast cell labs that I just do, like the VEGF and the transforming growth factor and the tumor necrosis factor, and some of like the IL-6 I'll order because these are mediators from the mast cells. And so I like to just sort of get a clearer picture of how those mast cells are misbehaving if they are. They usually are, as we know. So I just like to, and then, and as we always talk about in masterminds, I mean, I think that a lot of those labs are just notoriously difficult to get reliably just because of the way they have to be handled. So I feel like the more mediators that we can test for, the better picture I have of what those mast cells are doing, and also sometimes where they're doing it, because the mast cell mediator population can be different based on the different organ systems. And so I very regularly do some additional mediator assays. So but other than that, I mean, I do the same as you. So yeah, just trying to get a clear picture because again, as you've said, these patients have seen a ton of doctors, have been sick for often years, if not decades. And so clearly there's some physiology that's aberrant. And so if I can identify where that is, then it just gives me ideas to better treat the patients and to better understand their symptoms, frankly, even if I don't have a great treatment option or one that works easily for them, but does give me insight into why they have that they have.
I mean, our patients, we label, not label may not be the right word, but we use the term complex illness on purpose. I mean, that's a very thought out term for us, and it implies that it's not simple and straightforward. So no surprise a CBC and a CMP are normal, and
Right.
no surprise that when we order 35 tubes of blood, we discover a lot of abnormalities. It's a really important concept. And those abnormalities then at the next visit will prompt additional labs, and now it
Yeah.
becomes more guided and focused.
Exactly. And that's what I explain to patients. There's a
Yeah,
lot of labs, but we're gonna start to streamline as we
right.
learn what is going wrong. I very often get patients who will say, oh, this was tested like 6 months ago. And sometimes I'll say, okay, that doesn't need to be retested then, and I'll just take it off the requisition. But sometimes I explain that things are normal until they're not. Things seroconvert, as we refer to it as, where it was normal 6 months ago, perhaps it's not normal now. So it's there are some labs that are worthwhile to check in on again.
Yeah,
I like to point that out to patients.
yeah,
Yeah.
I'm really glad you're bringing that up, Eileen. That's really important because it's not conflict, but it does cause a little bit of back and forth with a patient, and they'll say, well, why are you ordering this? I had it done last year. Yes, I have antibodies. You know I have antibodies. Well, those change. That's the whole point.
Yeah.
These are, we are living dynamic creatures and everything is changing all the time. So, yeah, I'm not going to repeat your MTHFR genetic mutation lab because that's never going to change. Okay, that's it. You're born with it and you're going to die with it. But your early antigen for EBV or your VCA or EBNA or your ASO for strep could change in 6 months, you know, and I want to see those changes.
Right.
So it's a really important point because it does cause a kind of why are you spending all this money in my blood to repeat what I already did?
Right. Right. Yeah, I mean, I think it's the nature of actually trying to do chronic and complex illness well, right? You can't be persuaded by a normal lab that was done a year ago. You have to just sort of go with, trying to repeat it so that you can find answers for the patient. I mean, 'cause I always sort of explain that, well, if you didn't need my help, like you wouldn't be seeing me, right? So like I just want to make sure that things are still normal. I mean, and if they're still normal, then that's good. We can move on, but I know that sometimes things do seroconvert and you're not going to know it until you retest it. Um, so there's some questions in the chat. Question is around ionuphoresis and plasmapheresis. Why could someone's baseline worsen after doing them? Could it only help patients who have an inflammatory autoimmune profile and may worsen the condition of patients who are immune exhausted and have persistent viral bacterial infections? Could it also just shift the whole system too aggressively for some? I like this question. So ionusphoresis, I think, um, which is not done in the US, certainly, at least not yet. But and so I've had a couple of patients go out to, I think it's Switzerland.
Germany and Switzerland, I think.
Germany, yeah.
Yeah.
Um, the problem I don't know if there's a problem. I don't want to call it a problem. But the difference is that the ionusphoresis uses a filter and they just remove the plasma, they filter it, they return it to the patient. And a lot of patients prefer that as opposed to the plasmapheresis, largely because they don't want donor albumin, which I understand. But the problem is that I keep calling it a problem. Again, I don't know if it's a problem. I think it should be studied. We don't really know what is being filtered out and what is being returned. And I think that's where a lot of the research should go with the ionusphoresis. And then the plasmapheresis, of course, we just remove the plasma, we replace the volume with albumin. And so I guess so they're different, I guess is my first point. So it's hard to just sort of generalize the answer to the rest of the question because they really are different. Like with ionusphoresis, it could potentially be because of something that was not filtered out.
Right, right.
Uh,
I mean, the filter in the iontophoresis is not, it's not like a sieve. It's a limited filtration process. It's only taking out certain things.
Right. And so I know there's been talk about trying to study the filtrate so that they can identify what is actually being filtered out and what is potentially being returned. So, we do plasmapheresis in the clinic and I haven't, to be honest, I haven't seen it worsen someone's baseline. I've seen it not be as helpful as I had hoped it would be for the patient, but I certainly haven't seen it where it's worsened their baseline. Um, so I don't, but yet, so yes, the presumption is, of course, is that there's some immune mediated problem going on, and we're removing those immune mediated mediators. And that could be from both the innate and the adaptive immune system, right? So obviously autoantibodies. I mean, plasmapheresis in general, FDA approved for autoimmune diseases, which are by definition that there's an autoantibody. So we know it's removing autoantibodies, but it also removes a lot of the innate mediators that come from the innate immune cells, including the mast cells, which have 1,200 mediators. And it's removing mediators else from other cells, of which can also help the mast cells because the mast cells often have receptors for those other mediators from other cells. So the goal is to just remove all of that. And that's what the plasmapheresis is attempting to do. So if something is not immune mediated, again, either innate or adaptive, then plasmapheresis is not necessarily indicated. So yes, if someone is immune exhausted or immune depleted, immune deficient, immune compromised, there is a potential of not a great effect and certainly I theoretically a worsening effect from plasmapheresis. So, I think that, and then with regards to its use with persistent viral bacterial infections, I mean, so I once asked you this question, David, like, how do you explain a plasmapheresis recommendation to a patient with, for example, chronic Lyme?
Right. So I'll answer that in 1 second. I just want to back up a little bit.
Mhm.
Um, I think it's important to point out it's not just in plasmapheresis now. We're talking about taking all the plasma and discarding it. We just throw it away. It's a sledgehammer approach to a complicated illness that we don't ultimately know all the causes for. Right. And yes, that's not very elegant in terms of we're throwing the plasma away and what are we throwing away, but that's what we do. But it's not just autoantibodies and mediators. It's also particularly in long COVID patients, it's microclots, it's misfolded proteins, it's junk, it's stuff that shouldn't be in our plasma that I think, and there's evidence for, that it gradually accumulates in the face of chronic inflammation in the exact same way that that's what happens as we get older. Okay, there is a connection between the diseases of aging and chronic long-standing inflammation and complex illness patients with ME/CFS, long COVID, dysautonomia, et cetera. And theoretically, and I think practically, those products, those molecules are being removed in plasmapheresis. In terms of infection, it is not a treatment for infection, and I try to emphasize that clearly. However, there may be benefit in reducing the burden of infection, i.e., any organisms that are floating around in the blood. If you're bacteremic or parasitemic or even viremic, so bacteria, parasites, virus, those are going to be removed. That's going to be discarded along with the rest of the plasma. That doesn't mean you're cured, right? The infections are still, maybe intracellular or in the tissues, but that reduced burden helps the immune system to recover, number one. And number two, the albumin that's reinfused has its own immune boosting and anti-inflammatory properties, which further increase the patient's ability to fight infection. An argument I make, and I think it's true, and it's not just me, is that we can't depend on drugs to cure people of infections. They need a competent immune system. It's a two to tango kind of process. And in that sense, I think the plasmapheresis can be beneficial. Would I take a patient who had nothing wrong, in quotes, except for chronic Lyme and do plasmapheresis? Probably not, because I'm not sure I have enough evidence to prove what I just said. Um, but in terms of the patients we see who have multiple other reasons to have it done, I think it makes a lot of sense. I wanted to comment on the problems of getting worse after plasmapheresis. Like Dr. Ruhoy, I have not really seen anyone get significantly worse. There is definitely a period of fatigue. And I think that our patients so often are hemodynamically unstable, meaning their blood pressure, heart rate with POTS and dysautonomia, that um, we need to be cautious in the process of plasmapheresis because of that, because you have these big shifts of fluid. Theoretically, we leave the patient as net zero, meaning we put in as much albumin as we take out plasma, but there's still the exchanges going on, and that's important to
There still
recognize.
is a fluid shift, and I always
Right.
warn patients that certainly after the first one, and potentially even after the second one, you can feel fatigue and dizzy and even some nausea, but that resolves. And there are delayed improvements, certainly with plasmapheresis, because just by the sheer act of, I mean, it's very crude to just think we're just going to dump something and then you're going to have a marked response. The body has to recalibrate, and when the body is no longer provoked by something that's inflammatory, that's pro-inflammatory, it takes a little bit of time for those pathways to sort of reset itself so that the body isn't as inflamed and that some of the physiology can get back online. And that doesn't happen immediately. And so I often will tell patients, after their sessions that while they don't yet experience an acute benefit or don't think that they do, that, give it some time. And, that seems to hold true. There's been a couple of patients in recent times where I had a 3-month follow-up and they reported, improvements in a lot of
Yeah.
their symptoms. So there is a delayed response. And when you think about physiology and how complex that is, it does, this requires like, protein, translation, transcription. It just requires a whole lot of physiology to take place for the benefits to be realized.
Right.
So yeah.
Yeah. So, there was a Carmen Scheibenbogen paper, um, maybe 6 months ago, 4 months ago, really good paper looking. So there's not a lot of work on plasmapheresis with patients like ours. Okay. So her work is just like that. Those are the patients she sees. And in that paper, there is beautiful documentation that the changes, the improvements come 2 to 3 months after the procedure, which is a really important finding because most of us, including me, frankly, would have said, well, you're going to go in there and have this big procedure done 4 times, 6 times. You better feel better by within a week. But
Right.
it doesn't work that way. It takes a while, as Eileen is saying. I have a question for you, Eileen, and for anyone listening. One of the things I've noticed in patients that they tell me as an improvement, which I never expected, is improved sleep. Have
Oh,
you seen that?
all the time.
It's so
That's
amazing.
when I was just talking just now about improvements. I mean, the sleep improvement was coming to my
Very
mind
early.
very early. Everyone
Yeah.
they sleep much better. Yeah,
Yeah.
no,
So
for
interesting.
sure. Yeah, and
And that alone makes it worth it because sleep
I
disorder is so
well,
profound in our patients.
and I am of the opinion that healing and recovery is just not possible if someone is not sleeping
Right.
well. Because so much restoration and rejuvenation happens while we sleep. And so we can do all of our best while patients are awake, but if they're not sleeping at night, then we're only going to go so far. We're not going to get to true
Right.
recovery. So I agree with you. I mean, it's a win. Patients are sleeping better. It's a win for everyone. So yeah, I love that. Can you go over vagus nerve stimulation? A lot of patients have adverse reactions. There's a new VNS that's red light instead of electric stimulation. Any thoughts on red light therapy, titration generally and specifically for VNS or cognition function? Um, Adverse reaction to vagus nerve stimulation. I mean, that's not uncommon. And I think, there's different kinds of vagus nerve stimulators. When I trained, I mean, the only vagus nerve stimulator I knew about was the ones that are implanted for epilepsy patients. Um, and then when I got on into private practice and started doing more chronic and complex illness, then I learned about all these ones that you can just buy on the internet. So, and I will say that I haven't heard a lot of adverse reactions. I have heard where they don't feel good from it or hasn't been helpful. I do think that the vagal nerve stimulator holds some promise for different symptoms and diagnoses, especially with anything that's a neuronal hyperexcitable state or hyperactive state, of which it's not only just seizures. In fact, in the world our patient population, I see it all the time. I do think that, for example, a very common symptom that I see specifically in long COVID patients, interestingly, but is that like a visual snow or other visual disturbances. And that is known to be sort of a retinal, which is part of the brain, retinal hyperexcitability, a cortical hyperexcitability, but also, some of the different brain foggy kind of symptoms are related to hyperexcitability. So I think that a vagal nerve stimulator holds some promise in treating that. I find that a lot of these patients and these particular symptoms that I relate to cortical hyperexcitability are very responsive to different anti-epileptics, which just sort of proves that point, right? So that's sort of how I see it because they will respond well to specific anti-epileptics, and not all of them, and some of them actually come with a lot of side effects that I wouldn't use for that indication because I use them off-label because obviously these are not seizures in the way we think of seizures, but they are a neuronal abnormal state. And so, and often think, I always think about the microglial activation and how that's playing a role, and the mast cells, can contribute to microglial activation, and some of its mediators certainly do. So anyway, that's where I think a vagal nerve stimulator has some promise. And while I have not seen it be a magic bullet for any of these symptoms or any of this kind of physiologic state that I'm describing, I do think that, it theoretically it should help at the very least. With regards to um, the red light, I didn't know that there was a red light option now.
Yeah, I
What
didn't either.
what's the name of that brand? I'm curious, but yeah, so I don't know about, I mean, I like red light therapy. I think it's anti-inflammatory, but I think you have to be careful in sort of like deciding that this is going to like cure you. I think all these things are adjunctive is how I see them. Anything that will reduce inflammation, I think is okay in my book. But we have to find something that truly moves the needle to get patients better for sure. And I think red light therapy is great, and I think it's proven to be very anti-inflammatory and can certainly be helpful along the way. And I'm interested in this vagus nerve stimulator that is red light based. So I'll look that up.
Yeah, I would just, I mean, I've been disappointed with the vagal stimulating devices and patient reports. I have rarely had a patient say, wow, I feel so much better.
Yeah.
Um, I mean, I think it's fascinating biology and technology, and I think that some of the work out of by Kevin Tracy, I think his name is, has been really, really interesting, but I haven't seen it as effective in our patient population. He's using it in rheumatoid arthritis and things like that.
Yeah.
Red lights, as you know, I'm a big fan of. Um, Although I know nothing about its use for vagus nerve, if it's literally just a single light for the
Mhm.
vagus nerve. But I think red lights are important. They reduce inflammation. They can improve mitochondrial function by activating an enzyme. So I think, and many, many patients will tell me they feel better with it.
Yeah, and so the patient said it's V light, which I actually have seen.
Yeah, so V-Light I thought was brain. I didn't know it was for Vegas. Okay.
It asked me and a few of us at Renegade Research to test red light VNS. Would love to chat more with you about it. Well, I'm definitely open to doing that for sure.
Yeah,
I've
definitely.
definitely seen ads for it. I just never looked into it, to be honest. I mean, yeah. there's just so much I could research about. I'm always being forwarded. What are my thoughts on this and what are my
Yeah,
thoughts on that? And I know you are too, David.
yeah,
Yeah, it's only so much time in a day. So, but I'm definitely interested in learning more about the V light now, knowing that it's red light. Um, okay, back to the questions on the YouTube page. Um, we did the labs. What does a low CD57 signify? Is it some sort of chronic reactivated infection? And what if a clear infection can't be found? Can COVID persistence lead to it? So, I mean, you can certainly pipe in, but what I understand about CD57 is that it's useful for chronic Lyme diagnosis, right? Because doesn't it indicate an active infection or at least a persistent infection? And so for chronic Lyme, I thought that some of the Lyme literate doctors were using the CD57
yeah.
marker.
Yeah, the CD57 is being used that way and has been for quite a few years. I don't actually think it's particularly helpful myself. I don't order it at all. Um, I think there are a lot of other ways to try to figure this out. And it doesn't, I think there's probably many reasons that CD57 will be low or normal or high, and I don't think we understand it. So I just don't find it that useful. Um, and I have not heard or seen anything about its use in long COVID and what it does. I'm not aware of anything. There may be studies out there, but I haven't seen them.
Okay. Did have a question for you about, so in one of my neurology journals, or it's not really a journal, it's one of these just like these magazines that we get. They talked
Throwaways.
about it, right, throwaways.
That's
Um,
what they're called.
they talked about, and I kept thinking, oh, I have to ask David about that. But they talked about chronic Lyme and how their study showed that piperacillin was way better than doxycycline. And did you know this? I was shocked
Yeah, that
in
study just
my neurology stuff.
came
Yeah,
out very recently from the same groups that discovered that most of the drugs we use don't work on the latent stationary phase of these organisms. These are tick-borne infections. And also the same groups that learned that other drugs can work on those latent phases like disulfiram and methylene blue and couple of others. Rifampin works on both. So the piperacillin then in this study showed itself to be very, very effective. The problem, of course, is it's intravenous,
right.
and we don't know how long to treat. So it's exciting, and I'm sure there'll be an increased question and demand to try it, but it's not a simple decision. It means a PICC line or a central line and all the risks entailed in that.
Got
And
it.
I don't know in this study, I think it looked mostly at replicating, not stationary phase. I'd have to look again. I don't remember that.
Yeah, I don't remember either, but I was excited to sort of see that at least in some parts of the neurology world, we're talking about chronic Lyme
Yeah,
disease.
that is a
What?
surprise in a
Yeah, it was
neuro
referring
journal.
to Lyme.
Wow.
I
Yeah.
know. I was like, oh, this is nice. Okay, back to questions from patients. I've been diagnosed with post-viral fatigue after having EBV mono back in April of 2020. I do have an awesome PCP that helps with my many symptoms. My question is, what type of specialist do you recommend for me? Um,
So the first thing I would ask that patient is, are you sure that was post EBV or did you have COVID and not know it? Right? Think about the date,
right.
April 2020. That is when COVID smashed into this country, and most people still were not aware of it. Well, no, that's not true. Everybody was aware of it because New York was dying, but the testing was not adequate, and I would be suspicious it's actually long COVID that this patient's describing. That's pretty arrogant of me since I have no idea anything about the history, but just based on the chronology.
Right. I mean, there are labs that can confirm a mononucleosis. So I'm just wondering if those labs,
Right, right.
yeah, so who knows? But you're right. I think that in 2020, especially in April, we knew about COVID, of course, by April of 2020, but I don't know if it was as rampant of a post-viral concern because it was acute back then. And I remember in April of
Yeah,
20,
they were dying. That was when,
I was just going to say that
millions.
that's when the news would show like the makeshift morgues that were being
Right,
built in the
right.
parking lots of hospitals.
So actually, it's a great question to prompt this conversation. So, if the patient was told this is EBV they have, I would want to know what the labs were. If that just means that the doctor drew a serology antibodies and the VCA and the EBNA, these are two of the IgG antibodies, were moderately elevated, or even very high and the patient's young, like 25, that's totally meaningless as far as I'm concerned, especially in April of 2020 when the world is falling apart from COVID.
Right. Exactly. Yeah. It's
But
it,
in any case, and I'm sorry, Eileen,
but
sorry.
don't be sorry.
Um,
I don't.
it, to some point, it doesn't matter. You uh, post EBV fatiguing illness and post COVID fatiguing illness at the end of the day are very similar, if not the same.
That's what I was
So
going to say.
I guess I'm being a little bit nudgy on this, but
Right. No, but that's
yeah,
exactly what I was going to point out. I mean, we know that post-infection syndromes are very much the same. There's a common denominator. It was the infectious exposure and the actual physiology of it. I think, we're still sorting out. Clearly, there's been a lot more research on long COVID, and now there's lots of theories as to what is contributing to the long COVID kind of phenotype. And, we're learning a lot of different things about what COVID does to our body physiologically. And so I think our challenge will be to apply those theories to ME/CFS, for example, or which I think a lot of us think is often is a post EBV kind of thing.
yeah, I think the whole language is changing now. I mean,
Right.
in terms of the physician community, we're talking about uh, post-viral fatiguing illnesses or post-viral immunologic disease, which is really a great bit of progress if you think about it. Okay, so that's
Yeah.
something we can be grateful to COVID for. What was the other part of the question after?
What type of specialist do you recommend?
Oh,
Yeah. I don't, the thing about these syndromes is that they're multi-organ involvement. So I don't know if there's a particular specialist until we come up with a residency and fellowship program for
right.
eating illnesses and post-exposure, post-infectious syndromes kind of thing. I think that just any doctor that has worked with patients with these chronic illnesses would be the specialist that you need. Yeah, like Dr.
Yeah, I mean, um, what I would like to say is that any well-trained internal medicine doctor who remains curious and interested and thoughtful can do this. The
Yeah,
problem is, as everybody knows, the primary care doctors who are often trained as internal medicine doctors, the vast majority are employed physicians and they have to see patients every 10 or 15 minutes. They're not allowed to think out of the box by their employer. Not the doctor may want to, but they are constrained. They're not allowed to prescribe off-label often. They're not allowed to do anything that's not quote evidence-based or quote guideline-based. And so really smart internal medicine doctors don't stay that way. I hate to say it like that, but so there
yeah.
is no specialist in this work.
I mean, sometimes I think that I wish infectious disease doctors would play more of an active role for these different syndromes for ME, CFS, for example, and or long COVID. I really do think their insight is sorely needed, and that's sort of how I see you, David, and as an infectious disease doctor, and that's why you've been so useful and
Right.
successful in helping these patients, just because of that perspective of infectious disease, and I know that it started with your HIV experience.
Yeah.
But I'm
And
often surprised that more infectious disease doctors don't, jump in to the game.
yeah, no, it's profoundly disappointing.
Yeah.
Mainstream ID docs, IDSA, Infectious Disease Society of America, I mean, they still don't recognize chronic Lyme. They
I,
still don't believe it, and it's very sad.
yeah.
And I guarantee you, the patients listening now and the ones that may, excuse me, listen when we post this on YouTube, they've been referred to ID docs and they've been just totally ignored and gaslit and nothing's wrong with you.
Right.
It's very sad and depressing.
It is sad. And I had shared when we were doing that mast cell web panel thing, I shared with you that I even just recently was talking to an immunologist who said that he and his colleagues won't see MCAS patients. So, and I should have pursued the line of conversation, but we were at a dinner but where are these patients supposed to go? That's like,
Yeah,
I feel sad for them. I really do. I don't know where they're supposed to go, where they're supposed to seek help if, the true specialists in a particular field are not willing to entertain an idea that's outside of the box, right? Because I think once you start to think about outside the box, then those things are no longer outside the box,
right,
right? They
right.
become inside the box. So. So yeah. So anyway, so that's what type of specialist we recommend for you. What are your experiences on patoxyphylline and cytomegalovirus? Does it promote replication of CMV? Oh, does it?
I never heard that.
Me neither. I mean, my experience with pentoxifylline, which I've prescribed a bunch of times over the last couple of years, largely because I like its blood thinning properties, but also it's got some antispasmodic properties. So a lot of the patients, what they describe to me reminds me of like cerebral vasospasm, of which there are a couple of those syndromes in neurology. It reminds me of that. So I like the fact that it's got some antispasmodic properties, though not very strong, but it does do that a little bit. Um, and a lot of patients do think that it helps, but I haven't seen it be like that useful where I'm like, that's the first thing I'm thinking about prescribing for patients. But I had never heard that it promotes the replication of CMV.
Yeah, I've never heard that.
Okay.
I'd love to know where that came from.
Okay. Yeah. I mean, I'm gonna Google it at some point, but because that'd be curious to me, of course.
Yeah.
Do you have any questions on the Patreon page? Because the final question on the YouTube page has to do with people really unhappy with me and my practice model change.
Oh, we'll skip that. Um,
I'm happy to address it, but I think that if there are other particular questions that are
I
probably
don't really see community. No, I don't see much here. I don't see anything here. Did you see questions on Patreon?
I did because I get emails when people post on the Patreon page, and so
Oh, no, I haven't. I don't see it.
oh, okay, well let me go to my email then. Um, yeah, there's actually a bunch. You don't see them
What do you look, where are you looking?
under the where we post that we're doing a live. What I love about the Patreon community is that it looks like other patients were answering.
Oh, I see. I'm sorry. Yeah.
And actually, there's a couple of
These are old though. These are 2 months old that I'm seeing.
no, so there's a couple of ones that are saying that they're looking at the where the Patreon is paused, and so they feel like the podcast is paused, is what maybe that's the reason why she still can't get in. Oh, so there's a bunch of comments that patients can't get in. Look at that. Oh, that explains the the audience today.
Yeah.
Apparently there's several comments where people were having a hard time getting in, and I don't know. And they're all talking about they haven't been able to access the session. All right, well, I'll have to sort that out, figure that. And I did realize that YouTube allows us to do a live session. I mean, there's a live YouTube.
Yeah.
Maybe we just try that next time because I don't know why. I didn't do anything different than I normally do. Oh, look, one patient is saying that it was asking for a passcode like you had to do, David.
Right. Right.
So I don't know the difference. And now people are asking for the link for today's Zoom. Okay,
I
well,
posted the link again on Blue Sky, but
yeah.
I didn't know where else to put it.
All
But
right.
I mean, this will go live right away, right? We're going to put this up on YouTube right
I'm
now.
gonna post it right now. And so we weren't looking at the Patreon page, and I obviously wasn't looking at my email while I was on the Zoom meeting. And otherwise, I would have seen that there are several people that had a hard time accessing this session, and I didn't know we didn't know it until now, which is now, of course, at the end of the session. So probably not worth the time to sort of figure it out. But we're gonna post this now anyway. Just know that we're sorry. And the next time we're going to try to do this through the YouTube live option. This has always worked so well in the past that we just continue to do it this way. And clearly it wasn't working today for a lot of people. So we apologize for that. We had no idea.
All right.
Yeah.
No other questions out there
Anybody on
from
the
the people listening, watching, who got on somehow?
anything in our last few minutes you want to ask a question? Anyway, I mean, I could say something about apparently there's been a lot of unhappy people posting in the Facebook patient groups about me and the change of my model. And I was even interviewed by a reporter with regards to why, and it wasn't just about my model, but David, this applies to you too, why doctors are so expensive for patients who are chronically ill. And I always talk about the patient-doctor relationship and how it needs to be therapeutic. And I think it has to be therapeutic. It's like every other relationship in your life with your partner, your children, your parents. And it takes a lot of time. It takes a lot of back and forth with patients and with their doctor, which, in this scenario, of course, is me. And I just really believe in the therapeutic nature of a patient-doctor relationship because it worked for me when I was a patient. And my radiation oncologist was actually serving as my neuro-oncologist, which I know these specialties are somewhat obscure and most people don't know their roles, but my radiation oncologist had no business like ordering my MRIs and having follow-up appointments with me. But I trusted her and she trusted me. She got to know me over the years, and it was really therapeutic for me. And then she retired, and then I'm left with a radiation oncologist who doesn't want to do anything but give me radiation and doesn't really want to have a conversation. And so I really feel that the therapeutic nature of the patient-doctor relationship is so important. And I had so many patients that I was not therapeutic to anyone at that point. And again, it's not about the labs that I order or the medications that I prescribe. It's really about the getting to know the patient, getting to understand them and who they are and their symptoms and how it affects them. And I didn't have the time to do so. So I had to make some hard decisions. And a lot of us, have gone cash because insurance won't reimburse for that time. And I can assure you that both David and I think about patients like 24/7. I mean, it's all we talk about when he and I talk when we get together. It's all we talk about, it's all we think about. My husband's always complaining that I'm on my laptop 24/7. So it just takes a lot of time, and insurance companies, which are brilliant because we, of course, look like the villains and the bad people, but they don't reimburse for the time that's spent to really get to understand these patients so that we can really figure out how to help them. And so it came down to some hard decisions of which I, still am like apologetic about. I just didn't know what else to do. And I've gotten softer. I've made some concessions since that decision. And but because really I'm just vested in, I want to make an impact before I die. That's sort of how I see it. And so I'm vested in just trying to help people, but I also have to pay my staff and pay the bills and keep the practice open. So it was a hard decision, and I'm sorry that I made so many people unhappy. I'm going to cry because I got some really nasty emails, which, really didn't make me feel good. I don't have that thick of a skin, but I'm trying my best, and I'm apologetic to everyone who felt like somehow I abandoned them, that I made a decision that now precluded them from seeing me as a patient. But, I just, yeah, I mean, and I'm not, and that's my explanation. And I don't know if it's good enough, and I'm sorry, but I also don't want to get like nasty emails. So I just felt like I had to, in some way, because this patient, the question on the YouTube page refers to the patient groups of where everyone is like complaining and even points out that no one came to my defense. And I realize it's because I made the announcement in a very like, I probably could have explained it more when I made that announcement. And I apologize for the way I went about it. But again, it wasn't an easy decision for me to make. So I think that on some level, I even felt uncomfortable announcing it, but I didn't know what else to do to sort of keep my sanity and keep and continue to do the kind of work that really has made me not burn out, right? This kind of work is exciting to me and has infused, more excitement for me to do neurology and medicine. And so I just didn't know what else to do at that point. So I apologize and I'm sorry that I have so many unhappy people. People are unhappy with me. But do you want to say anything about
Yes, about you? No,
me? Yeah, are you
no,
unhappy
no. I
with
want to talk
you
about this
hate me
issue.
too, David, now?
No, no, I want to talk about the issue because although I have not done what you've done in your practice, I do charge a lot of money, and I'm very, very aware of that. Um, you know, an easy explanation, as you did, and as it always comes up, is related to the insurance system. It simply will not reimburse for the time we spend. They won't even reimburse for half the diagnoses we use, you know? I can put down I can't think of an example, but a diagnosis and order a lab test, and the insurance will reject the lab test because they say, "Well, we don't think that diagnosis is relevant." Well, they're full of shit. They just don't know. It's unbelievable. Um, so one, the system won't compensate enough for the time we use, and I think what gets lost, and you said something about it, but I want to reemphasize it. What gets lost in the conversation of how do you justify fees of this level is the amount of time and work that goes into it. I and you and almost every doctor I know on Masterminds, this listserv that we have, they are 24/7 working, reading, publishing, researching on this stuff. Okay. If I were a lawyer and I'm not trying to say anything negative about lawyers, if any of you are lawyers, but I'm using it as a model. I would be charging by the hour for the fact that from 9 till tw midnight, I'm reading, and I would somehow allocate that time to some client, all right? Or I would do it over and over and over as if it was brand new, all right? Lawyers charge by the hour, and many of the doctors are starting to do that. I know some doctors that are charging by the minute to answer email messages, portal messages. I can't wrap my head around that, but I understand the rationale. And I would add that there's 750 doctors in our listserv masterminds. I think there's probably only three people that take insurance. Everybody else. And over, doctors in that listserv have left their academic jobs because they can't deal with it. They get burnt out and they can't see the patients long enough, and they go private and cash and they thrive. So unfortunately, the people who suffer are the patients who don't have the money, and I don't have a solution to that other than figuring out some endowment system or fee reduction system. But I'm just me. I'm not going to manage that on top of everything else. So I just don't have a good solution.
Yeah. Yeah, I mean, it's a tough question and a difficult question, and I don't know the answers. I really don't. I don't know the right answer. And I'm open to ideas. I'm receptive. Like I want to help everyone, but I'm just one person. And I think about these patients all day, every day. And if I'm reading something in a journal, I come across things that I think, oh, that patient, this might explain this patient. It's just a constant,
Exactly, exactly.
right? It's so anyway.
It's
So
also, I have to say one more thing. It's also one of the ways that anyone who works in a service industry or cognitive industry, um, it can be a volume issue. So if the fees go down, then the volume goes up. Okay, so a primary care doctor in the hospital system is seeing 20, 25 patients a day. Okay, I I am this is an exaggeration, but it's how it feels. Barely functional at the end of the day if I see five patients. It is. It sounds crazy to me because in New York, when I was doing HIV, I would see 15 in a day. But the level of cognitive effort is huge and it's exhausting. And then all the keyboarding and all the note writing and all the lab ordering and all the fighting with the insurance company to get something paid and looking for a diagnosis that'll fly through and fudging the system. It's exhausting. And therefore, I could never do this 5 days a week. I mean, I can't even imagine doing that. And I don't think it's a function of my age. I just think it's cognitively almost impossible to do
Well,
it.
you bring up a good point. So we also have to deal with the regular shit of medicine, which is what burns out other doctors, right?
Right.
All the noting and the charting and the clicks and the insurance issues. Even though we don't take insurance, we still have to engage with insurance to get approvals for labs and imaging and so on. And I'm constantly trying to like coordinate patients and the different surgeon appointments and consults that they have and placing referrals. And so all that usual stuff of medicine that has been burdened the doctors and the reason for a lot of burnout, we still have to deal with on top of all of that. So again, I don't like to complain. It's certainly not my nature to complain. It doesn't feel comfortable to me because I became a doctor. I took on this job. And I love my job. I love what I do. I'm excited when I wake up in the morning to see patients. But I had just so many patients that I couldn't do the kind of medicine that I want to offer, and that frankly I feel that they deserve because they've already been gaslit and dismissed by so many different doctors and specialists, right? So I wanted to do a good job, frankly, and I just had too many patients and I didn't have enough time. So
Ironically, I just posted, I think yesterday, the an older episode on doctor patient and the system, why it's so hard to do what we're doing in terms of the healthcare system. So you don't have to watch that one, anyone who's listening to this, because we just did it.
right. Yeah, and we have a couple of others coming up. I'm excited to post the most recent one that we recorded, but I think we have to wait a
We
little.
still have to wait a little longer.
Okay. Well, it looks like okay, well, I'm all ears. I'm all ears, Kevin. So
Yeah, if you have a second, I can go tell you what I've been working on. I used to be, can you hear me?
I
Yeah.
can.
I used to be one of the top researcher analysts in Medicare. I got law from the president or the senators and translated it into language so that we could put it into our claim system, and all the doctors and everybody can speak the same language. And so I got long COVID, right? That's how this usually works. Changed my life. And now I'm spending all my time trying to set up a clinic like yours to help long COVID patients, and we're going to be taking cash too. And so my solution to this is to create a new form of health coaching, which is chronic illness health coaching, and start with somebody like me, a research analyst with the patient, and document as much of it as we can on the front end before they get to you all to save you all time in a way that you would like it and understand it. And then on the back end, we're all going to have to start, whether we like it or not, I think, using AI scribes to to free up your time again. And this is all designed to free up your time, right? The physician's time, so that you can spend your time doing what you need to do. Like you're talking about the new red light therapy and everything. Well, yes, you're reading too much. You're spending too much time doing that. You should offload that to someone like me. You know what I mean? A top researcher to do it for you, and then have conversations with me about what's going on, versus you spending 20 hours looking it up. Let me do it, and then I can put together something that can train everybody versus you all training yourselves one by one by one by one by one. And I know that health coaching was saying they were saving $4 for every dollar spent. It was saving $4, so Medicare was paying for health coaches. But that's very much lead a horse to water kind of thing. You have to make the patient say, what it is they're coming there for, what they want to get healed for. And so that works sort of, but with somebody with severe cognitive impairment, they might not even remember what they were saying 30 seconds ago. I lived through that, right? You're in the
Yeah.
middle of a sentence, you have no idea. So having someone that's a coach that starts working with you when the doctor can't spend all that time, and you can charge less for me, um, would free up a lot of time. I can be available by text and email and all those things like you guys are, but it's sort of a triage. And then the only time we need to let them through is when they really need to get through to you. And then it's all about saving time for you. It's because I work with a doctor and he's really busy. And so I've been trying to set up my clinic and take, offload things from him. So I started reinventing things. Um,
Kevin, this is really interesting. I would love to pursue this conversation offline. I'm working with a website developer. I don't know what label to use for him, who also has long COVID and has decided to set up a website for complex illness. And basically, what we're trying to to build is exactly what you're saying, which is the website would help put the data, the patient history, and all the old information together using AI to organize it, and then putting together protocols. The purpose of all this being to help the patient then go back to a primary care doctor and help that doctor maybe begin to take care of the patient, even though they don't understand it all, if they're willing to learn it. And also, we were talking about providing coaching through this website, exactly the way you're talking about. So it would be good to talk.
Yeah.
Yeah, I'd love to talk to you more about it. I'm working on it too. Like I started on my website just putting all my research under, all the different categories for the symptoms. But I've learned about some new AI tools that are really going to speed that up now.
Yeah. Well,
But
I'm a
yeah, I'd love to talk.
huge believer in not reinventing the wheel over and over and not competing on good ideas. So
Yeah,
let's
I
talk.
agree. Yeah.
I don't have a way to contact you, but I think you have our contacts. So maybe
I
you just,
don't. I just found you. I found your link on Reddit. Somebody just was like pasting it on Reddit, and so everything I've learned about you two, I've learned today,
Oh,
this
wow.
meeting.
Well, then you have so much more to learn.
Yeah, well, it
Yeah.
seems like it.
Yeah, no, I mean, I would love to talk more about this because I have had those ideas because I've had a couple of patients who are like they refer to themselves as health coaches who have offered to sort of help in ways that you've just sort of described as sort of being an intermediate kind of step between me and them. I just haven't been able to have the time at least to sort of sort out how that would work exactly. And so I'm definitely interested also in having further conversation.
Okay, yeah,
great.
that'd be great. Do you guys just want my email, or
Yeah, if you want to
should I
put it in
email
the
you?
chat.
Okay, yeah. So okay, that's what I got.
Yeah, I feel bad that there were so many people trying to get into this session, David, and they couldn't.
Yeah, I know. Maybe
Uh,
we'll do another one sooner.
yeah, we should do
We can
one
do
next.
it in a week or two.
Oh, in a
Yeah,
week.
2 weeks, 2 weeks. I don't know.
Well, we were doing it every other month. Maybe we just do it next month, just to.
Okay.
Okay. Okay, great. Thanks. I'm gonna copy and paste this,
You
Dave.
have it? I don't see it here. You
It's in
got
the
it?
chat. Oh, you
Yeah.
did. Oh, it's Kevin. You did it to just me.
Okay,
Oh, I
that's all right.
did.
You
How
can
did
send
I?
it to me. That's all right.
Okay. I'll send
All
it.
right. Well,
All
thank
right.
you, and this is great.
Yeah.
Good. Okay.
All right. Well, we'll all talk soon again. We'll see you
All
soon.
right. Thanks for
Thank
those that found us. Thank you for joining.
you. We're gonna post this to YouTube actually today. It
Good.
just
Good.
uploaded. Okay.
Okay. Bye all.
Bye-bye.